Hi everyone, this is Shivam Gupta from Johns Hopkins Bloomberg School of Public Health. Today I would like to talk for 15-20 minutes about Public Health 3.0, an organizing framework that can help us think through different health sector reform initiatives currently going on in India and reimagining a healthy India by transforming the role of public health in India in light of the COVID pandemic. Outline for this presentation is as follows. I'll start with a brief discussion on background and rationale for Public Health 3.0, the five key components of Public Health 3.0, and its relevance to the health sector reforms in India. How did the term Public Health 3.0 originate? It mirrors the three broad phases of public health development in the United States. These phases relate to broad historical background as presented in the document, and different people might have different views about it. Public Health 1.0 was the period from 19th to early 20th century when public health became an essential government function. This is the time when the state and local health departments were launched and systems for sanitation, food and water safety, development of vaccine and antibiotics occurred with the establishment of the field of epidemiology. Public Health 2.0 refers to the late 20th century to early 21st century, where the field transitioned from invisible public health safety nets to public health programs. This led to the development of multiple vertical disease-oriented programs that in some cases led to fragmentation of service delivery. This phase also coincided with a greater emphasis on standardization and professionalization of public health agencies. Good example of this professionalization are the essential health public services that form the basis of accreditation of public health departments and training curriculum for public health professionals. The two agencies that standardized these essential public health services were the World Health Organization and the Centers for Disease Control in the United States. What you see here is the familiar public health wheel from the CDC, where the 10 services are grouped under three core functions of assessment, policy development, and assurance. So what were the gaps in Public Health 1.0 and 2.0 and thereby the rationale for Public Health 3.0 approach? Some of the major gaps included the increasing recognition of the public health silos created by the more disease-oriented conventional vertical program structure and its inability to successfully manage non-communicable diseases and emerging diseases like Ebola in the past and currently COVID-19. And therefore, the greater need for horizontal integration reduced the fragmentation of service delivery. Moreover, there is a greater need to have an explicit focus on socioeconomic and environmental determinants of health outcomes to reduce the structural causes of inequities. And that requires a workforce able to work outside of a biomedical paradigm. Public Health 3.0 focuses on building capacity and developing local health leaders and collective action by the community to bring about positive change in its health. COVID-19 pandemic has made these gaps glaringly visible, catching the policymakers unaware with an urgent need to transform the way public health is practiced. We believe Public Health 3.0 can be an important way to move forward. Public health is what we do together as a society to ensure the conditions in which everyone can be healthy. As I mentioned at the beginning, Public Health 3.0 is an organizing framework that focuses on pioneering local public health agencies to build upon their historic success at health improvement and expand attention to the social determinants of health, which are the conditions in the social, physical, and economic environment in which people are born, live, work, and age. The framework makes a strong case for using multi-sectoral collaboration to achieve health equity. The Public Health 3.0 approach at its core is a means to convert public will to public policy. It leverages multi-sectoral collaboration to directly address social determinants with local public health agencies at its core, serving as a chief health strategist in their communities. For a community to address fundamental drivers of health through collective impact while establishing readiness and resilience to crisis, it requires five components: effective leadership, strong public health infrastructure, strategic partnerships, usable data, and adequate funding, as you can see in the figure on the right side of the slide. I will talk a bit about each of these components now. The first component of Public Health 3.0 is leadership and workforce, that lays its primary emphasis on empowering local public health leaders to become chief health strategists, focusing on upstream changes in social determinants of health rather than managing multiple disease-oriented vertical programs. In the Indian context, this could be envisioned as the district and block level public health officials working as chief health strategists for their communities, mobilizing community action to strengthen infrastructure and form strategic partnerships across sectors and jurisdictions. Second, essential infrastructure focuses on using accreditation to standardize public health services such that every Indian is served by nationally accredited public health agency that can ensure quality of services. Third component is strategic partnerships that focus on creating vibrant, structured, cross-sectoral partnerships beyond health and develop mechanisms to energize collective actions. Fourth component is reliable, granular, actionable data available to local communities with clear metrics of success, along with the capacity to analyze and safely manage access. And fifth is enhanced and flexible funding that uses innovative approaches to blend and braid multiple sources with the ability to recapture and reinvest generated revenue to support infrastructure as well as community level social determinants of health. In talking about some of the current evidence on Public Health 3.0, we can refer to the accomplishments of Nepal, Sri Lanka, Cuba, and other stalwarts of implementing the Declaration of Alma-Ata. Here I would point you towards the recent book by Dr. Bishai and Dr. Schleif with the title Achieving Healthcare for All, Primary Health in Action. Collective impact being a key mechanism for the Public Health 3.0 approach, there are several studies from the United States that present evidence on using this approach to focus efforts on one condition in one place. For example, reduction in opioid overdosage rates in Wilkes County, North Carolina through Project Lazarus, and reducing new HIV diagnosis and the time to viral suppression in San Francisco through Getting to Zero initiative using collective impact for Public Health 3.0. Longitudinally, we can look at the national study of public health systems by Glenn Mays and colleagues involving 16 years of data from 360 US communities, where incentives and infrastructure to support multi-sector population health activities were associated with reductions in geographic and socioeconomic disparities in population health. Now, I would like to highlight a selected, not exhaustive, list of items from the Indian context for each Public Health 3.0 component. What are some of the current issues in the Indian context and the proposed or ongoing reforms that can contribute to the Public Health 3.0 approach for each component? For leadership and workforce, the Indian health system primarily relies on clinical professionals who are primarily taught using the biomedical paradigm and have limited public health training. In general, public health professionals get very little training on public health practice. For example, they lack essential skills that include cultural competence, strategic thinking, team building, collaborations, networking, communication, and community engagement. A move towards Public Health 3.0 can be seen in the very active effort to expand training to non-medical professionals in India and also expansion of training avenues through curriculum, and though curriculum and competencies are quite diverse with limited standardization. For essential infrastructure, the Indian health system is composed of multiple vertical programs with diverse standards and variable quality of care. The system has weak linkage of primary health care with secondary and tertiary care. There is a range of regulatory accreditation framework that vary in scope and focus. Move towards Public Health 3.0 can be seen in the strong focus on integration of services under National Health Mission and the linkage of primary with secondary care being a crucial expectation from the Ayushman Bharat initiative. There has been active effort to establish and implement standards and accreditation systems. For example, the Indian Public Health Standards and the National Accreditation Board for Hospital and Healthcare Providers, NABH. Several laws and policies have been developed across health and related sectors. However, much work is needed to contextualize and implement in a multi-sectoral collaborative manner. For strategic partnerships in the Indian health system, the existing partnerships primarily focus on reproductive child health with limited engagement of private sector or other sectors and ministries. There exist limited examples of successful community involvement based on local autonomy. Move towards Public Health 3.0 can be seen in states identifying new areas of need for partnerships, intersectoral initiatives by Government of India, for example, the Poshan Abhiyan, Swachh Bharat Abhiyan. Additional examples include public-private partnerships as part of the National Health Mission and now Ayushman Bharat, and the multi-sectoral dashboard for monitoring and evaluation of aspirational districts by the Niti Aayog. For data, the Indian health system is composed of multiple data systems for each vertical program with limited standardization of data fields and responsibilities. It is currently impossible to link records for a user across multiple data systems, and there is very low capacity for data analysis at the local level. A move towards Public Health 3.0 can be seen in the creation of India Stack and the National Health Stack, and the recent launch of National Digital Health Mission that envisions a unique health ID for every Indian with linkage and portability of records across data systems and sectors. The integrated health information platform plans to be a single operating platform for disease outbreaks and morbidity profile for every citizen. For funding, the Indian health system is characterized by extremely low health spending in the public sector, which is mostly line item based, supply side, and with extremely high out-of-pocket expenses for healthcare. A move towards Public Health 3.0 can be seen in the National Health Policy's commitment to increase healthcare spending to 2.5% of GDP by 2025. Demand-side financing as envisioned in the Ayushman Bharat and other insurance schemes. Capitation-based system, flexible funding approaches in National Health Mission as performance incentives, and the social impact bonds that are becoming more prevalent and visible through the engagement of private investment for social improvement. Now, we have talked about each component and Public Health 3.0 reforms that are underway in India. However, Public Health 3.0 can be envisioned just like an orchestra where different instruments come together to create beautiful and unique music that is greater than any individual instrument. Similarly, for Public Health 3.0, different components need to come together in a unique manner depending on the context to operationalize Public Health 3.0. We believe examples of success do exist in India. We need to learn, document, and more importantly, institutionalize them for scale up at higher level. The recent Niti Aayog report on India health sector reform is consistent with the Public Health 3.0 components. Guidelines are available for basic approach to Public Health 3.0 implementation, which include development of a quality of public health practice task force, broad stakeholder consultation across health system levels and multiple sectors to determine key performance indicators, and using those to develop a self-assessment tool, which in turn is then used for regular self-assessment and professional development plans for public health agencies. In summary, Public Health 3.0 is an organizing framework to enable health systems to meet challenges of 21st century. And earlier in the presentation, we talked about non-communicable diseases, emerging diseases, and inequity. The primary goal of Public Health 3.0 is to translate public will to public policy through collaboration across different levels of health system and different sectors. India is making progress on all 5 components of Public Health 3.0. What we need is to learn from existing successes, institutionalize these lessons, and scale up for wider impact. Thank you.